All right, I do no disclosures, and we'll move up forward to the objective slide. Today, we're going to look at, we're going to review the different treatment settings for which alcohol detoxification generally occurs. And then we're going to focus today on outpatient alcohol detoxification with what we call ambulatory alcohol detoxification. Keep in mind that most of our patients aren't great candidates for outpatient alcohol detoxification, but there are situations in which it can be done successfully, and we'll kind of go through some of those situations and kind of what the process is for that, and then we're going to then review just that detoxification process. I just repeated myself, but just to repeat from last week, we talked about the symptomology and the core cause of alcohol withdrawal. This graphical illustration shows that GABA glutamate balance that we've talked about before, which in a non-alcoholic person, your GABA and glutamate has a general homeostasis balance, GABA being your inhibitory transmitter, kind of repressing transmitter, glutamate being your activating transmitter. And as you begin to drink, your brain, alcohol works on GABA receptors to cause GABA release. And so your brain becomes kind of low energy level, and after a while, if you're doing this regularly, your glutamate's going to try to counterbalance that and get you back into homeostasis of a balanced thing, as you see on C. But in people who have physiological tolerance or daily alcohol use for a number of months, when they stop that, all of a sudden that GABA glutamate balances because you've removed the external GABA activation, but your brain is still upregulated in terms of the excitatory glutamate activation. And alcohol withdrawal is always going to be more of a excitatory experience when that's the only thing that's going on, meaning it's going to increase your blood pressure and your pulse and cause extreme anxiety and insomnia. Next slide, please. These are the common symptoms of alcohol withdrawal. For most individuals, alcohol withdrawal is going to onset around 6 to 8 hours after their last drink, or in some cases, they can actually still be drinking and have alcohol withdrawal if they greatly diminish the amount. So maybe they were drinking a handle or 1.75 liters of alcohol, and they went down to, a couple shots. They could actually still have withdrawal even though they'd had a couple shots of alcohol, and that's it's due to that just general difference in the amount. But most people, when they go into withdrawal, have stopped drinking altogether. And within the first 6 to 8 hours, as we talked about last week, this is when people get that and those initial symptoms. Usually their blood pressure starts to creep up, their heart rate starts to creep up. They may start to get a little tremulous in their hands. The anxiety is usually the first thing that hits people. They start feeling antsy and nervous. They can have nausea and vomiting, and they get insomnia. So most people have alcohol withdrawal, have these symptoms, and most of patients I see stay in these symptoms. So they don't usually progress to further, but there is risk for more severe symptoms. 8 to 12 hours after the last drink or a significant reduction in the amount of alcohol use, people can have what they used to call alcoholic hallucinosis. And this is going to be psychotic perceptual experiences where people will have auditory visual hallucinations. But at this time, they're going to have a clear sensorium. So these individuals aren't confused. They're just having these experiences, these odd experiences, like what for most of my patients who've experienced this, they've had it before, so they're quite aware that this is from the alcohol withdrawal, but this is not a good sign. This is something I need to get taken care of. We've all heard of alcohol withdrawal seizures, and the time frame for those is usually half a day to 1 day. So when people have seizures from alcohol withdrawal, it tends to be within the first 24 hours. And so be aware of that. And our patients some people think it can take several days when it only really takes a few hours to start to have that risk of seizures. And seizures themselves generally aren't fatal, but can be fatal in extreme situations such as aspiration or choking on their tongue per se. And so we definitely don't want people to go into seizures. It's distressing because they can fall and hurt themselves. They can have muscle breakdown that clogs up their kidneys. There's things that can happen medically that causes long-term problems for people with seizures. And then the dreaded thing that we have, the worst thing we worry about is something called alcohol withdrawal delirium, or what internists for years called delirium tremens. And this is usually these individuals they're going to be confused. And that confusion can be alternating, so they could kind of be in and out. We call that a delirium, where they have a fluctuating mental state and orientation state. Generally, that is accompanied by agitation, where people feel very angry during that time point. As well, many times they will have those psychotic or perceptual symptoms, where they have hallucinations, where they think someone's in the room, or they think someone's about to harm them. And that's different than that 8 to 12 hour alcohol hallucinations frame, because they're also confused. And so they're in a delirium state, not just with psychosis. And so the psychosis likely at that delirium state is from the delirium itself. And so for any of you who have worked with delirium of any type, which can be caused by any drug or a lot of drug intoxications or withdrawals, but also medical conditions, that people tend to get psychotic. Next slide, please. So these are our main settings in which we will potentially treat alcohol withdrawal. As I mentioned, we're going to focus on ambulatory today. Ambulatory, again, meaning outpatient treatment of alcohol withdrawal. We don't do this very often, just because there's a lot of recommended criteria for doing so based on risks factors. And alcohol withdrawal, if it goes into a delirium, can be fatal, and it can lead to really systemic cardiovascular collapse in extreme cases. And so, if we have someone that we have any risk of that happening to, we're not going to do that in outpatient. We'll want them to go inpatient. So the vast majority of alcohol withdrawals are done in what we would call a general medical / psychiatric setting. This would be your medical hospitals, a normal floor, non-ICU or non-intensive care floor in your medical hospitals. Psychiatric hospitals also do alcohol withdrawal, particularly for those who don't have significant comorbid medical problems. So if they're also having a renal failure at the same time, you're going to go to the medical hospital. If they have complicated medical non-psychiatric problems going on with withdrawal, those people are going to go to the medical hospital. And I think you all know what I mean by that. Like in Tulsa, that'd be like St. Francis, St. John, Hillcrest, those situations. If you have someone who doesn't have those risky medical problems and maybe even has a co-occurring psychiatric disorder, then a psychiatric hospital can do that. And a lot of substance use treatment facilities do that as well. And again, they're not going to be able to treat, neither psychiatric or substance use treatment facilities have IV access generally. So this is, if you have someone who's seriously medically or has significant medical problems, those are not going to be the places you want. And then lastly, when we talk about treatment of delirium, we'll talk about the ICU setting, which is where delirium treatment starts. It should be started. And then generally you can step them down off the floor once the delirium starts improving to a regular medical floor. I kind of already said all this stuff. So next slide, please. Got ahead of myself. And so how do we start determining if someone needs to go to a certain setting or which setting they need to go to? Well, we have to do an assessment, of course. And so hopefully your patient's not already in delirium. If they're already in delirium, your assessment's going to be pretty difficult in terms of getting information, and but you're going to see that pretty easily on your physical exam or their presentation. But if your patient can talk, we want to get a detailed alcohol use history, looking at how long they've been using, have they been using daily? So if you have a binge drinker who hits 14 drinks once a week, they're much less likely to experience withdrawal than if you have someone who's drinking 5 or 6, 7 a day on a daily basis over a long period of time. So binge drinkers can have withdrawal, and I've seen cases of it, but it's very uncommon, especially if they're only binging once or twice a week. But your daily alcohol users can definitely have withdrawal. And generally, that risk of that occurs in people anytime after 1 to 2 months of consistent use. And everyone's going to differ. And so some people will experience withdrawal after a couple months of use, and some people may be able to drink alcohol for 2 years and not have withdrawal when they stop all of a sudden. You also want to know how much they're actually drinking. Of course, people who are drinking more than you would expect humanly possible. Probably means they've had like handles, I hear, 1.75 liters of alcohol. It means they've built up to that because they would be dead if they hadn't. And those people, of course, are going to have higher risk of withdrawal. Time of last drink is important because we looked at the time frame earlier on the slides, and so you definitely want to know when they had their last drink or when they cut it down significantly, because that's going to tell you when to start expecting withdrawal symptoms in someone. So if their last drink was 2 hours ago, they're probably still intoxicated if they drank at handle, and they're probably not at super high risk of withdrawal at that point, but we know they're drinking that much, that risk is coming in a few hours. And we want to take that time to prepare and get them connected with the adequate treatment. And then any previous withdrawal history. So have you been through alcohol withdrawal before, and what was it like? Because we know that if you've had seizures before, you've had hallucinations before, or you've had delirium before, you're more likely to have that again in the future. And so that can help us determine, help us determine that they need to be in a probably not an outpatient care level for sure. And they need to go in the hospital and get prepped for trying to prevent that from happening. Look at other substance use as well. So it's more difficult to do an outpatient alcohol withdrawal detox if they're also using multiple other substances. That those people need to go inpatient generally. And then medical history, as I mentioned before, if they have significant medical or surgical complications or problems, maybe they have problems absorbing medications because of gastric surgeries, you're probably going to want those individuals in a medical hospital, not an outpatient clinic. And then allergies, of course, if they're allergic to the main medication you're using to treat that on an outpatient basis, of course, you're not going to do that at your facility or if that's what you have available. Next slide, please. Mental health history. So people with significant mental health symptoms like suicidal ideation, homicidal ideation, or currently manic or psychotic, you're not going to want to do that on an outpatient basis either. They're going to need to go either to a psych hospital or a medical hospital to get detox. Family history, social history, and social history is really important with ambulatory because you want to know what their living environment is. If they live at the day center, they're homeless, and you're sending them home with benzos, those are either going to get taken or probably stolen by other individuals, and that's not someone you want in an ambulatory setting. And is there someone there to watch them? Because even in the best cases, sometimes things go badly. So is there someone who could report back to you if they start having symptoms after we sent them home with some benzodiazepines? Laboratory screens can be helpful, looking at liver enzymes. So if their liver's in bad shape, you probably don't want to do that ambulatory or outpatient as well. And then we want to know if they're taking other drugs. And then they'll look at their BAL. If their BAL's 300 or 400, they probably need to go to the hospital and don't need to be in your clinic right at that point, particularly if they're altered in any way or form. And then do a physical exam, of course, looking for any medical complications from alcohol that may indicate that they need a higher level of care. Next slide, please. So some of what I consider contraindications, and some contraindications are not always absolute, but some of the guidelines that I use personally are these. And if they have these things, to me, this says they need I don't want to do this in clinic. I don't want to be giving them a taper to send home overnight and coming back. And so those contraindications, again, include other substances of use. And that's unfortunately very common in our field. Most people I see aren't just using one substance. Certain substances, of course, are going to be more worrisome. So if they're also using benzodiazepines, giving them benzodiazepines, abusing benzodiazepines particularly, is probably not going to be a good plan because they're probably going to use them all and then put themselves at risk for withdrawal. If they're on opioids too, you're going to have a double withdrawal probably. And so you're going to need a double detox, and that becomes complicated on outpatient. If they're using methamphetamine, any kind of hard drugs, it's going to be more difficult because they're less likely to comply with what you're doing because they're going to be using those other substances. Some people don't worry about it with cannabis use, particularly if it's regular, and that's going to be up to each provider in terms of, are they comfortable with giving someone benzos who's actually using cannabis? There's not a lot of direct, risk for respiratory depression with that combination, and so some providers have different opinions on cannabis. If they have uncontrolled diabetes or serious cardiac or pulmonary conditions, or some kind of acute infectious process, don't try it on the outpatient. They're going to need to go to the hospital. I already talked about serious psychiatric illnesses. And if you have a pregnant lady, you want to be in a place where you can monitor fetal activity as well, not just, and you can't do that consistently and regularly if someone's going home after a few hours. So next slide, please. As I mentioned before, if they've had previous history of seizures or delirium or what we call more severe symptoms of alcohol withdrawal, they're likely to have that again, and you don't want to do this in clinic. Unhome safe environments, if you can't get a hold of them, they don't have support, they don't have a home or a solid place to stay, not going to be a good candidate for ambulatory. I already talked about benzos and barbiturate addiction. And if they've tried ambulatory, this is your third time trying it, you probably need to give up on it and send them into the hospital on the second try. So when people fail ambulatory, it's for different reasons. You give them, we'll walk through the process, but you basically dose them a couple times in your clinic, and then you send them home with the last couple doses. And a lot of people will just take both those doses immediately, or they're drinking alcohol on top of the benzos, which gives them risk for gives them risk for respiratory depression and overdose if they're doing that. So, or they're using other drugs on top of it. And those are all going to be cases in which people fail ambulatory detox. Also, if they decompensate despite what you're doing, that can be considered failure. So their withdrawal gets worse. Next slide, please. So few things you want, if you're going to think about doing outpatient alcohol detox, some things you want to be aware of. You want to know, can they get back and forth to their appointments on a regular basis? Probably something you should determine before you start prescribing them a benzo on a daily basis, essentially. Is there someone there that can watch them and be provided education on what withdrawal is and when it's time to call for emergency services or call the clinic? And want to have that individual available 24/7 for them to somewhat monitor it. And keep in mind that I was always taught in psychiatry that a family member monitoring a patient does not neglect your need for not doing the appropriate level of care. So you feel someone needs to go to the hospital, you're not going to diffuse your responsibility by having someone with them. If they don't meet criteria, they don't meet criteria, no matter how badly that person doesn't want to go in the hospital. Next slide, please. So if you're going to do this on an outpatient basis in terms of, alcohol withdrawal or detoxification, some things you have to think about. Generally, this is going to require at least 4 or 5 days of daily monitoring in some form. Of course, the initial visit, you yourself probably should be making contact, as the provider should be making contact and evaluating the necessity and need and if it's appropriate to do so. But even on the subsequent days, I recommend having them come in. Usually for the first day, the physician or the provider, will see them. That usually takes an hour, and then the nurse, of course, will see them right before then. And then if they're at a point where they're already in withdrawal, we can start dosing them that after the encounter and the determination of it's okay to go forward with this on an outpatient basis. So the first day, worst case scenario, is usually about 4 hours. So I try to dose them quickly if they're in withdrawal, and then give them their second dose before they leave. Some people will keep them there 6 hours, even based on how long it takes to get through that intake process. So the first to 2 days can be up to 4 hours. I would recommend that you have some kind of tool that you use. We touched based on the CWAL last week, and the CWAL is just a way to give you a more objective number to tell you how bad someone's withdrawal is. Your staff can be taught to use this, or you can use it yourself as the primary, if you're the primary provider. But with people, we're going to reserve ambulatory withdrawal for milder withdrawal. So if their CWAL is over 20, we're probably not going to try this in the clinic. That means their risk of decompensating on an outpatient basis is going to be much higher. So definitely take blood pressure and pulse too, because if those get into dangerous areas, even after you dose them with medication, specifically benzodiazepines, then they may need to be in a higher level of care as well. They likely will need to be in a higher level of care. Anticipate about 5 to 7 days of withdrawal symptoms, knowing that the risk for seizures is highest within the first 24 hours, and the risk of going into delirium is the highest within 72 hours, but can occur after that, especially if untreated. And I always remind people, detoxification is not considered treatment for addiction. It is the necessary first step for safely getting someone off of alcohol. But detoxing someone alone and then sending them out without any kind of follow-up or treatment almost always leads to relapse on alcohol, or reuse or reoccurrence of use on alcohol. So while you're doing your detoxification process, start thinking about next steps. So how am I going to keep this person off alcohol? Is that going to be counseling? Is this someone who needs to go to residential treatment because they have really severe disease? Is this someone I need to put on naltrexone or another MAT for the long term? Next slide, please. So the medications we're going to use are going to be a type of medication called benzodiazepines. They are in the United States considered first-line treatment for alcohol withdrawal. If you look at European studies, you'll see that they'll use gabapentin and carbamazepine quite frequently, particularly gabapentin now for mild alcohol withdrawal. But generally, if I'm doing this on an outpatient basis and I can't watch them, I'm not going to use gabapentin personally, just because there's so much more evidence on benzodiazepines and the risk is much lower for you, and at stopping the progression of alcohol withdrawal. So benzodiazepines work kind of as an artificial alcohol, is the easy way to think of it. So they're hitting that GABA receptor that the alcohol has left unactivated, and they're giving a little bit of that GABA or inhibitory neurochemical release. They're activating it a little bit, and then you slowly wean that medication off so that the brain has time to counteract the glutamate. So the glutamate is trying to glutamate's realizing, oh, I don't need to be this hyperactive. That excitation starts to come down slowly. And that's the whole point of a taper, is just to give your brain time to adjust and to catch on to that there's been a major change in the homeostasis of these chemicals in the brain. So you can technically use any benzodiazepine for withdrawal. So there's not a wrong answer, but especially on an outpatient basis, the longer acting ones tend to be smoother and easier for you as a provider. So if you're using alprazolam, which has a short half-life, it's going to be more complicated to dose and to control symptoms. Whereas if you use something that's really long or has a long half-life or has active multiple metabolites like diazepam, which is Valium, or chlordiazepoxide, which is Librium, you generally are going to get a smoother detoxification process, because there's always some benzodiazepine or metabolite present in that system. And with those two, you're looking at 2 to 4 weeks of some type of metabolite present in the system. So they actually, even after you stop actively prescribing them the benzodiazepine, they're getting a slow taper off of that medication over a series of weeks. Of course, those are not going to be as liver friendly. So if you have someone with bad liver disease, you probably shouldn't be doing it with in an ambulatory setting anyways, and they'd be going into the hospital ideally. But you would use different benzodiazepines, particularly looking at lorazepam for individuals who are liver impaired. Again, but they're liver significantly impaired, that to me means they need to be at a higher level of care. Or if they're over the age of 65, they're more likely to fall on something like diazepam and chlordiazepoxide. So you got to be more careful with it, and you have to think about, is this someone I can appropriately treat on an outpatient basis? There's not an absolute contraindication to treating people over 65 in the clinic setting, but keep in mind that the medications you use may increase their risk for falls. Next slide, please. So these are, I've got a few slides of just example tapers that I use. This is not absolute, and you can use, you'll see variations of this based on different facilities and different providers. So with Librium, what I will do on day one is I'll try to dose them initially, and then dose them if it's like, try to get like around 4 hours. This says every 6 hours. Dose them second, and look to see if I'm trending the seawall and the vital signs down with that, or if I'm improving symptoms. And then I'll send them home with a couple of take-home doses of 50 milligrams. Well, they don't make 50 milligrams, so 25 milligram capsules of chlordiazepoxide. On day 2, I spread that interval out. So I'll come in. If they come in on day 2 and they make it back, we're going to talk to them. We're going to check their seawall, look at their vital signs, and dose them quickly and see if we continue to get positive response. And then we can let them go after an hour or two of monitoring for that, and then give them a couple take-home doses. And then day 3, I reduce the dose, same kind of process as day 2 with the lower amount. Day 4, same kind of process, except they're only going to take it twice a day. And with Librium, I usually have them come in on a day 5, but I have them hold the medication until bedtime. I'm just checking to make sure they're doing okay. So with this taper, I generally am asking the patient to come in 5 consecutive days. But it's, if they are well functioning, working, this is less just, and they're not significantly ill, either mental health wise or medical wise. And this is going to help them, stay in the daily process better. I don't necessarily want my patients working during this time, because they're going to be on a benzo and it's potentially sedating, particularly if they're driving anywhere. We're not going to say, hey, yeah, you can go back to work, take this Librium and head back to work. It's a bad plan, but they can do it from the comfort of their home. And some people who work from home now, which is common nowadays, will try to do a little work at home as well. Next slide, please. This is an example with Valium or diazepam, another longer acting one. So the big difference between diazepam and chlordiazepoxide is how fast the onset happens. So if you're looking for something that kicks in really much quicker, diazepam is going to kick in quicker, like within 10 to 30 minutes, people will start noticing the effects of oral diazepam, whereas with Librium, it can take up to an hour for some people. I won't read the taper for you. You guys can read that yourself, but this is just another example if you want to use that one. If you are doing outpatient, don't forget about the other medications that are necessary. So there, as we talked about last week, giving thiamine before you give glucose can cause brain problems. And if we're on an outpatient basis, we may not have access to that banana bag or IV administration of thiamine. And so you want to dose them pretty heavy oral thiamine dosing, knowing that some of that's not going to get absorbed. And so what they recommend is 100 milligrams of thiamine every 8 hours for the first 5 days of treatment during those active benzo use. So give them a lot of thiamine. And then after that, even for the next week or so, go ahead and give them 100 milligrams of thiamine daily. And you can continue that for several months if you want to. It's not going to cause any harm. If you're overtaking it, it's just going to be excreted, not cause any harm. Other providers also generally offer folic acid. Some people will tell them to take a multivitamin. Multivitamin is less necessary in my opinion, but you'll see a lot of providers who like it. And then in certain cases, you will need magnesium supplementation for individuals with neuropathy or severe withdrawal symptoms. If I'm having to give magnesium supplementation, generally I'm going to have those individuals in the hospital, honestly, because those are going to be generally given IM, and those are not things I want to keep in my practice personally, hanging around. Next slide, please. Educate your patient as well as the person watching over them about when they should call for emergency, call 911 and get emergency help. And this slide kind of goes through the basics of that. So, if they're having a seizure, call 911, get an ambulance over there. If they're confused or disoriented in any type, agitated in any type, have fever of any type, or hallucinating in any type, they need to immediately call 911. Certainly then call your office, but the person watching that individual needs to call 911 first, and then they can call your office so that help is on the way. Next slide, please. That might be it, yeah. So any thoughts, questions, comments from you guys?